Good day, everyone. Today, I'm going to introduce the topic of diabetic complications and management. I am Dr. Paul Chong Chen from the Division of Endocrinology and Metabolism from Changhua Christian Hospital. As we know, an epidemic of type 2 diabetes is underway, with 387 million people estimated to have the disease worldwide in 2014. Unfortunately, the International Diabetes Federation estimates that about 592 million people will be affected by type 2 diabetes mellitus by 2035. Currently, the prevalence of diabetes is about 10.3% in St. Vincent and the Grenadines, about 11.6% in St. Lucia, and about 11.8% in Papua New Guinea. If you refer to the table on the right, there are several known risk factors for type 2 diabetes, including genetic markers, family history of diabetes, and age is also an important risk factor for diabetes. The diagnostic criteria for diabetes is based on the risk of developing diabetic retinopathy. 3 criteria, including fasting plasma glucose, 2-hour postprandial plasma glucose, and serum hemoglobin A1C, are all able to predict the risk of retinopathy. Refer to the table below, we see that the 3 important criteria for diagnosing type 2 diabetes are as follows. At fasting plasma glucose above 126 milligrams per deciliter, 2-hour postprandial glucose more than 200 milligrams per deciliter, plasma hemoglobin A1C more than 6.5%, or random plasma glucose above 200 milligrams per deciliter, plus classical symptoms such as dry mouth, urinary frequency, and weight loss. Type 2 diabetes mellitus is associated with a range of complications that should be assessed on a regular basis, including macrovascular and microvascular complications. Also, common comorbidities such as obesity and obstructive sleep apnea should be assessed. Importantly, the patients often have high blood pressure or abnormal plasma lipids, which should also be assessed during every clinic visit. First of all, I would like to introduce the topic of diabetic nephropathy. Screening for urinary albumin excretion is a sensitive biomarker of diabetic nephropathy. This step is recommended at the diagnosis of type 2 diabetes and every year afterwards. The stages of nephropathy are as shown in the figure. Normally, the urine albumin level should be below 30 milligrams per day. When the urine albumin excretion exceeds 30 milligrams per day, the condition is termed microalbuminuria. And this is the earlier step of diabetic nephropathy. If we follow these patients annually, the patients may progress. And when the urine albumin level exceeds 300 milligrams per day, it's called macroalbuminuria. At this step, the patient's kidney function may progress, may deteriorate significantly. And patients also have increased serum triglycerides and total cholesterol. At this stage, the patient did not receive adequate treatment for diabetic kidney disease. The patient will have progressive kidney function decline and progress to kidney failure that require hemodialysis. So how to control patients with diabetic kidney disease? First of all, Adequate control of plasma glucose levels with hemoglobin A1C below 7% is essential to attenuate the kidney injury in type 2 diabetes mellitus. Furthermore, blood pressure control to levels below 130/80 millimeters of mercury using either angiotensin conversion enzyme inhibitors, ACEI, or angiotensin receptor blockers, ARB, is the cornerstone of diabetic nephropathy. These medications, as shown on the right, blocks the formation of angiotensin II and the subsequent increase in blood pressure and urine albumin loss. Now I'm going to introduce the topic of diabetic neuropathy. The prevalence of diabetic neuropathy reaches almost 45% after 25 years in type 2 diabetes. There are several forms of diabetic neuropathy, but the most important ones are shown below. First of all, large fiber neuropathy may involve the vibration sense and the proprioception sense of the patient. This neuropathy will increase the risk of falling injury to the patient. Second common form of diabetic neuropathy is small fiber neuropathy. This neuropathy often involves pain in the distal limbs and the impaired thermal sensation. The patients will be unable to feel injury to their extremities and may cause ulcer and limb amputation. To screen for diabetic neuropathy, we should use two tools. First, a 10-gram Weinstein monofilament to detect for small fiber neuropathy in both hands and feet. And another important tool is the 128 Hz bridle cipher tuning fork. This tool is used to screen for vibration sense and proprioception sense in diabetic patients. So as shown in the figures below, there are several points that should be tested for diabetic neuropathy in both the hands and the feet with the 10-gram monofilament. So if the patient has any problem with sensing the light touch from the monofilament at more than 2 of the points shown, then the patients probably have diabetic neuropathy and should receive further treatment. So the control of diabetic neuropathy to relieve the neuropathic pain in diabetes, the tricyclic antidepressants such as imipramine are very important for controlling neuropathic pain. Furthermore, duloxetine and pregabalin are also effective against diabetic neuropathic pain. The figure on the right shows the mechanisms of common medications to treat neuropathic pain in diabetes.